deep pocket exists between the first and second maxillary premolars. Its surgical elimination will be demonstrated. The topical anesthetic has been applied. A local anesthetic is infiltrated in the buccal and labial areas. It is all injected in the palatal tissue, infiltrating from the central incisor to the second premolar. Because of the looseness of the teeth in this area, they have been previously stabilized with the use of an aid splint, which consists of twisted stainless steel wire covered with acrylic. The splint extends from the premolar to the incisor and has reduced the mobility patterns to 0 in this segment. The deepest defect is between the first and second premolar. On the palatal aspect, there is a deep pocket extending into the osseous tissue. This actually is a bony defect, which is sometimes classified as an infrabony pocket with one osseous wall. After the anesthetic solution has been administered, the pattern of pocket is explored with a calibrated periodontal probe. This instrument is slipped into the pocket and extended to the base of the pocket. By laying the probe on the outside, one can see that the base of the pocket extends toward the mucogingival junction. This indicates to the clinician that the traditional gingivectomy procedure would be contraindicated. If pockets were eliminated, the remaining attached gingiva would be lost. Our objective must be to preserve attached gingiva as possible. Examination, including probing of the pockets, indicates the procedure of choice. Notice this area, where considerable depth is present between the two maxillary premolars. The procedure of choice in this case, which would enable the clinician to gain access to the underlying bone and eliminate the bony defect, as well as eliminate the suprabony pockets and preserve the attached gingiva, is the apically positioned flap procedure using an anal-fold incision. Dental radiograph shows the area in discussion. Note the aid splint used to reduce mobility of the involved teeth. There is resorption between the canine and first premolar. There is also resorption of the interdental septum between the first and second premolars. This corresponds to the area where a deep pocket was probed. This Crane-Kaplan pocket marker, 3 markings are made on the labial mucosa overlying each tooth. The purpose of using pocket markers in the apically repositioned is to enable the clinician to determine the location of the base of the pocket and the crest of the alveolar process. The flat edge is placed into the pocket, the beaks are brought together and kept parallel to the long axis of the tooth. Noticing that the pocket depth approaches the mucogingival junction, we can understand why the gingivectomy procedure should not be in this position. There is depth in the buccal and the palatal aspect between the prolapse. Once the pocket mark has been made on the labial and buccal surfaces, the same is repeated on the palatal side. We make a mesiopalatal, a direct palatal, and a distal palatal marking for each tooth in this segment. Again, the beaks are kept parallel to the long axis of the tooth. The greatest depth in this particular quadrant exists on the mesial of the second premolar and on the distal of the first premolar. One notes that the pocket markings extend for a considerable distance onto the palatal aspect. A Castroviejo blade breaker and knife are used to make internal beveled incision. This incision for the gingival sulcus will be aiming for the alveolar crest. An attempt is made to obtain the pattern of interdental papillae. The incision extends from the distal of the last tooth in the segment to the middle aspect of the maxillary central incisor. The razor blade in this area is a fine and thin internal incision. The same is repeated on the palatal speck. If the palatal tissue to use the razor blade for the internal beveled incision, a scalpel can be instituted to accomplish the same purpose. The internal beveled incision permits the removal of the inner lining of inflammatory tissue, the pocket. Here, reaching the incision, the palatal internal bevel will be removed. Once the internal bevel incision has been completed on the bull and palatal surfaces, the number 11 Goldman Fox knife, which is an interproximal knife, is used to cut the inner ring of the pocket. This tissue is removed from the palatal specks of all teeth in the area. Bags of tissue are also removed. Once this inner lining has been taken out, one will be able to reflect the flap. It is important to remove any loose tags of granulous tissue and here to accomplish a Goldman number 2 curette. The fewer tags inside the flap, the better the healing will be. The lining of the palatal flap is now being removed with a number knife, accomplished in strip, and in other instances individual tissue fragment removed. The osteal elevator is used to reflect a full-thickness palatal flap and enables the clinician to gain access to the lying bony deformities. Tissue has been reflected. The pattern of the osseous defect is easily seen. Distal to the second premolar, it appears advantageous to utilize a distal wedge procedure to take out a wedge of tissue and enable the buccal and palatal surfaces properly blended. It also will permit the contour distal to the premolar. The wedge of tissue is seen at the end of the probe. It has been dissected with a scalpel, will now be removed from the area. It will also permit distal past the second premolar. It will develop a trough, which could act as a food retention in that location. The intrabony defect is seen with a curette in position between two premolars. As it does not have 3 osseous walls, it is not amenable to reattachment procedure. It does not have 2 walls, one will consider the use of autogenous implant. The proximal wall appears the wall remaining, which is being by the periodontal probe. The contour and morphology defect guides the clinician electing osseous surgical method for its removal. Therefore, by osteotomy, one wall will be removed and the intrabony defect eliminated. The buccal flap is now going to be reflected. This is a thickness reflected by a periosteal elevator. It will permit access to the underlying osseous tooth and at the same time will retain the zone of attached gingiva on. Reflecting the flap enables the clinician to see the pattern of the underlying alveolar. Spray as you remove any fragments. The defect is seen between the 2 premolars of buccal. Cleaned out the soft tissue fronts with a curette, this pocket will be eliminated by the use of hand and rotating instruments. The instrument now being seen is here curette from the fragment of tooth left. are used to remove a small piece of the dental septum. That's the bottom of the defect. This begins the of the interdental problem between the maxillary first and second molar. A vertical groove or spay is created with this instrument. It is used to remove any loose pieces of bone and any remaining soft tissue fragments. Care taken to try and create a osseous architecture. This term implies the interdental septum extends more occlusally than the adjacent buccal. This is the shape prior to development of the defect. With a stat chisel, osseous contour to the use of the rating. The double-ended stat chisels are useful instruments in attempting to innate wall decks interdentally. Chisel may be worked from the buccal and go completely through to the palatal aspect. Can also be contoured from the palatal side. Coarse diamonds are used for contouring. Be careful to use a water spray and place very little pressure on the osseous tooth. It is important to be careful of the tooth structure in the area so that gouges or irritants are not made in tooth surface. Accentuation of the interdental tooth is also accomplished between the king and the first premolar. This will be repeated in areas. Debris fragments are removed with thread and addition. Of the bean chisels and new enables the clinician to create physiologic architecture in this premolar region. Curettes again are repeatedly used to remove any loose fragments. The procedure is repeated on the palatal act in an attempt to eradicate the bony defect between new premolars. Here we see the ocean bean chisel being used on the past to correct the bony contour between the premolars. The osseous tissues from the labial and one knows that the contour has been improved. No rise interdentally exists between the two premolars. This was reversed, in that the interdental tissue did not come down occlusally as much as both left. The interdental grooves are noted. That can be positioned about 1 meter or incisal to the crown and secured with either continuous or interrupted suturing and position flaps is rated in 2 of this film system.